Hello, everybody, and I'm very happy to be here and to speak in the webinar of the MINEC. I'm very honored, so I thank you very much, the Megagen family, for inviting me to speak here. I hope you will enjoy this evening. We will talk about the maturation patterns of peri-implant tissues. So let's begin with the program. Every time we face a case in frontal area, in aesthetic area, and we have to change a natural tooth and substitute it with an implant, we have several questions that actually needs more answers and more secure parameters in order to give us an indication on how to predictably replace the tooth and do not lose aesthetics, or perhaps enhance the aesthetics of the area. So anytime we face this area, we are trying to find rules in order to know what to do on Monday morning in our office. So we will be talking about the factors regulating the tissue shape and volume over the years around implant. These factors can be divided into three big sessions: the implant, the surgical, and the prosthodontic factors. Of course, this evening will be a summary, a very fast summary, because it's only 1 hour we're staying together, and in order to speak widely about this topic, we would need probably 1 week, and we will not finish the work. But let's begin with the summary on the most high topic on this issue. The surgical factors affecting tissue may be resumed on something that actually can be shared as the ideal site. What is the ideal site when we place implant, and when do we need to bone regenerate the site because the bone is not enough? So the amount of bone actually cannot be left to someone's experience in order to be judged if it's enough or not. Literature is full of suggestions, but most of these suggestions are very different one to each other, and they differ even from one systematic to the other systematic. So what kind of indications do we have in order to understand if that site is enough or we have to regenerate the bone because it's not enough? Let's begin with the case. In this situation, there is a substitution of a lateral teeth. There was an endodontic issue that couldn't be solved because of a lateral channel. But going directly into the point, an immediately abutment was placed at the time of surgery, and a connective tissue graft was stabilized buccally in order to protect the shrinkage of the site, and some low resorbable rate bone material was placed between the implant and the bundle bone. In this situation, an immediate provisional was placed, and the maturation period of 1 year shows that there is no remodeling of the surrounding tissue. If we compare the beginning and the 1 year post-op, we can see clearly that tissue is absolutely not receding. And even after 4 years, everything is very stable. I would like to know what is the parameter that gives this stability, because I would like to have this stability every time I place an implant in frontal area. You see here 5 year post-op and still is very stable. And the 6 year post-op control, again, everything is fine. If we had the chance to make a CBCT 4 years later, and you can notice in the buccal side of the implant that there is 1.5 millimeter of bone 4 years after the placement. So could this be a parameter that gives us a good prognostic positivity in the aesthetic outcome? So let's have a look on the values that on human works, because most of the values that we have derives from animal studies. We did this mapping the tissue around implants on human on quite a wide amount of patients. It's a prospective follow-up, 5-year follow-up research protocol with the consecutive enrollment of patients, so they were not chosen between good and not good people. So from day 1 to day X, all the patients who had to place implant were included in the study. The exclusion criteria are patients who needed guided bone regeneration and the general factors that avoids implant placement. There were collected 202 variables per each implant, and the implant placed were ranging at 6 months at 280 implants, approximately more than 200 at 1 year, and they were lowering at 100 at 3 years. At 5 years we were almost 43. At the end we ended up with a collection of 70,000 data that we had to analyze, but the baseline for the bone values were achieved at the surgery time. The baseline for soft tissue values were achieved at the final prosthodontic delivery, and those values were checked every month, every 6 months or every year up to 5-year follow-up. So you can see in the background the Excel that shows the amount of data, which is quite incredible, because if you try to print times the Roman 12 this Excel, you will find it's long 12 meters and high 2 meters. And when you check these data and try to find some connection between values, we can focus directly on the topic of the buccal bone. Buccal bone was measured after implant placement at time of surgery, and it was measured in the first 1.5 millimeter next to the implant shoulder. If we try to compare with the discrepancy and the maturation of the interproximal bone that was monitored through the intraoral periapical radiograph with a stabilized way, so the radiograph was stabilized with the ring centrator that was reliant directly on teeth, so the position of every follow-up radiograph was exactly the same and the measurement could be comparable between them. So I'm sorry, I think I have to restart the presentation. What we could see in the moment, here we go. Okay, I'm sorry for the delay. The bone resorption was significantly different when the buccal bone next to the implant shoulder was more than 1.5 millimeter compared to when the buccal bone next to the implant shoulder was less than 0.5 millimeter. But this actually is not a problem from the patient. We still know this situation, but what actually the patient care about is what happened to the tissue height. So directly with the tissue height, we measure the major distance between the zenith and the teeth shoulder. So what happens is that in this situation, when the buccal bone was more than 1.5 millimeter, we could register after 5 years of placement, from the placement, a creeping attachment of tissue. So we were having more tissue than what we had at the beginning of the delivery of the final prosthodontics. If we compare this data when we have less than 0.5 millimeter, we see that in that situation we have an average recession of 1 millimeter. So of course we need to have buccal bone, otherwise you can clearly see that it's highly predictable, this data, because the P is very significant. You might have recession when you don't have enough buccal bone. Enough buccal bone can be found in 1.5 millimeter, which is a statistical measurement. And what about the interproximal papillas next to the implant? We found out that actually those papilla have an influence deriving from the buccal bone width. If the buccal bone width is 1.5 millimeter, you have 5 times the extension of the papilla compared to when you don't have enough buccal bone, so less than 0.5 millimeter. So is highly also in this point, if you want to have extended papillas next to the implant, you even need to have keratinized mucosa around the implant. Not only because it's easier to keep it clean and lower the incidence of periimplantitis, but also because having a keratinized mucosa next to the implant increases the blood supply to the papilla. And you can clearly see from this graph that the more papilla height is compared with the more keratinized width at the buccal side. So it's highly suggested with, again, a high statistical significance that you might have at least 2.5 millimeters of keratinized mucosa in the buccal side. This is the last number, so you're not getting bored so much. The transmucosal distance in the buccal side was average measured at 4 mm as something that was giving the best performance in order to reduce the bone resorption. So when the transmucosal height was 4 mm, the bone was resorbing less and the tissue were remodeling less. So we can conclude saying this first part that if you have at least 1.5 mm of buccal bone after implant placement, you might have less chance to have recession. Probably tissue will be more stable. Probably you will have less bone recession and more extended papilla due to a better aesthetics. So making a resume of all this number, let's try to understand how to apply this in the daily practice. You have an implant to place and you do an examination, a radiographical examination, and if you have all these numbers satisfied, you can of course set an implant without big fear to have a problem, because probably tissue will mature this way. And this is demonstrated by all the numbers that I showed you at 5 years follow-up with high predictability. Of course, if you don't have, for example, enough distance between the interproximal bone peak to the interproximal contact point area, there is a very good article from Tarnow that suggests us that the chance to have a full papilla when you have more than 5 mm of distance between these two anatomical parts is very low. So what you might have in the maturation is to have a reduced papilla where you have a more distance than 5 mm from the interproximal bone peak to the contact point in the prosthetic part. And of course, nobody wants this. If you don't have enough buccal bone because you placed implant without bone regenerating when you should have done, after some time you will find out, probably after 6 months to 1 year or 2 years, tissue will recede and you will lose interproximal papilla and you will lose buccal tissue. This also happens to me, and you can clearly see in this case there's something wrong in this implant in the middle because it's not doing very good. Let's drive to a different point of view. The implant side again has some tips that can reduce the chance to have anesthetism in frontal area. Why do thread could be important for us? You have different design of implants, and nowadays I think the biggest match between all the companies is design of the implant. In the past decade, probably it was the surfaces. Nowadays, design is really effective. A huge amount of scenarios that actually are giving a lot of revolutions in everyday practice. But let's have a look to some of these points. If you take care about the design of different implants, you can see that at the tip of the implant you can have a design which is self-tapping, a very aggressive self-tapping, which is something that in the past was quite often used, very highly associated to implants placed in the mandible in very dense bone. You can have smooth tapping, so a kind of tapping that is not aggressive, is not removing bone while placing the implant. And you can have knife threads, so threads that are just inserting inside the bone without even destroying the structure of the bone itself. So what we are used at, especially in the past, is that for an implant of 4, for example, we do a hole of 3 or 3.25. And this mismatch between the hole that we do with the burr and the implant diameter is fixed by this aggressive tapping threads and at the tip of the implant. Because in this hole of 3 mm, when we place an implant of 4, something will happen. The buccal bone will be destroyed because the implant is wider than the hole in the bone. And of course, there is a gradient of density. The density of the bone in the palate side is higher compared to the buccal side. What happens is that this grinding effect will affect a reduction of the buccal bone wall. And considering the numbers that I gave you, if you begin with 2 mm, you're very safe against retraction of the gum during time. It's very easy not to have a recession around the implant, if the patient correctly cleans, of course. But if you have just 1 mm, your chance to have recession rises dramatically. So you really do not want implants that reduce the buccal bone, or you have to place implants very palatally in order to have enough bone after implant placement. That's why in my protocol, every buccal bone was measured after the implant placement. So you need an implant that flows inside the bone, just disappearing inside the bone. The thread's diameter is not something that reduces the bone itself. And another example, this is a 4.8 burr for a 6.0 implant. And again, this implant, which is 6 mm diameter at the tip of the threads, when you place inside a hole of 4.8, you can clearly see, please have a look, the threads disappear, and in place of the threads, the bone stays there. It's not destroyed. So we really need implants that leave bone around the implant itself, because if they reduce the bone, of course, can give us back some recession problems. And you can clearly see how much those threads, they are called cutting threads or katana threads, they flow directly inside the bone in order not to harm the bone itself. So again, if you have an implant that is not reducing the buccal bone, you will have less chance of recession, less chance of bone remodeling, and more chance to have a higher papilla around the implant. Else, a secondary effect of these knife threads compared to the ISO threads, so this is the normal ISO threads, which are normal screws that are used for the stainless steel, for example, and this is the knife threads that are used generally for wood screws. Of course, there is a very different stability of the implant after their insertion due to the fact that the surface in contact is very different. And a secondary effect is that the total amount of the surface of an implant that has this kind of threads, of course, is doubled or more. So you have much more surface ready for the osseointegration compared to the ISO threads. This means less days for a good osseointegration, less day waiting for the occlusal load, and more chance to have primary stability for immediate loading or for immediate placement, even after extractions. So let's see an example, a clinical example. Very simple cases, those are daily cases, because I would like to show something that happens daily, not special stuff, because special stuff is only for some days, happy days. But this daily stuff is something very easy. Everybody would like to place an implant exactly in the middle of this septum. But as soon as you do a burr, and you can clearly see here, there is really a sheet of paper of bone surrounding this hole. It's very thin, this bone. And if I use an implant which is aggressive tapping, this thin bone will be broken. And of course will be a little bit more difficult to stabilize the implant. And in my soul, I really like to have native bone next to the implant surface, not bone regeneration, even if it's not a difference from a literature point of view. But you can clearly see that after implant insertion, this very little amount of bone is still there, is still intact, it's not destroyed. So we need implants that are not destroying bone. This is the healing at 6 months. This is the radiograph. And what happens to the tissue? Here there is a creeping, because we had enough buccal bone. And we could guide through the good emergence profile, and we will be speaking about the emergence profile soon in a more coronal position. What is the side effect of this kind of threads? Is that, of course, in dense bone they cannot cut so well. So we need to increase the preparation only in dense bone. Because if you do not increase the preparation, you might income in over-torquing condition. Please remember that generally in most of the implants, if you reach more than 90 newtons of insertion torques, you are making a permanent deformation of the internal connection. We will see something about connection quite soon, and you will see that it's a very bad thing. You will not discover this, you will not see this, you will not understand that this is happening, but this happens. So please never overpass 90 newtons. Try to stay inside the newton that the company suggests to be safe, so 50 to 60 newtons is more than enough. So let's change the topic again, and let's have a different point of view again, from a prosthodontic point of view. So what stabilized tissue over time from a prosthodontics point of view could be a little complex, because it deals with emergence profile and biologic width. The emergence profile is something that influences highly the position of the free gingival margin. So anytime you change something inside the tissue, the free gingival margin will interact as a stimulus by displacing itself and maturing in a different position. If we are speaking English now, and people speak Korean or French or German or Arab or whatever you like, tissues speak one language, and this language is shape and bacteria. We need a lack of bacteria in order to have healthy tissue, and we need a good shaping in order to have a mechanical protection for tissue. Let's begin with the case again. And in this situation, you can clearly see that majorly there's no possibility to have a papilla, because the interproximal bone peak is probably 4 mm far from the CAJ of the medial tooth. This is a milky teeth on an adult patient. He's 40 years old, and his hygiene condition is not very good. This is plaque. And he was reconditioned by our hygienist, and when he went a better cleaner, we could begin with the implant positioning. So you can also see that the sinus is quite low, and this patient wants immediate low due to work problems. He doesn't want to wear masks, he doesn't want to wear Marylander, he doesn't want to wear nothing. So he wants a good solution, and he's somebody that is highly highly busy for work, and we need to do a very good solution for him. He becomes a trusted patient because we work psychologically on him a lot in order to let him understand that immediate loading success also depends from him and his ability on cleaning tissue. And we removed the tooth and we did an immediate implant positioning. Even we did immediately the provisional, which is of course not in function, nor occlusally, nor in guidance. So when we shape the provisional and we have a more accurate view, we can describe what is called the S-line emergence profile. What is the S-line emergence profile? S-line is a shape that can be drawn, where inside the tissue, so in this area, is a concavity. And outside the free gingival margin, it becomes a convexity. And this is very important, because the convexity gives the ability to the prosthodontics to make a mechanical protection to this tissue. Nowadays, a lot of researchers are re-evaluating a lot of mechanical disorder on tissue around implants, because there is no periodontal ligament. And that tissue has nothing that gives stability to itself, nothing except what is called the connective ring. So when you have a switching platform design of the prosthodontic and the implant platforms, and an S-line, so a concavity inside the tissue, around this collar there will be some fibers, some collagen fibers that will give an O-ring stabilization of this tissue. This tissue, which are stabilized, of course, suffer less than tissue that are not stabilized by the connective ring, which is the only thing that gives stabilization. Why stabilization is important? Because if the tissue moves, bacteria can leak inside. And of course, this is not positive for those tissues. Else, it's concave because of another reason. The less titanium and the less resin you leave in that position, the more blood supply and the more connective tissue thickness you will have. So blood supply and connective tissue thickness is something that, of course, is promising better stable results compared to thin tissue and less blood supply. So again, I repeat, outside the tissue it must be convex. What means that you find an equator around the tooth that gives a shadow to the tissues or surrounding the implant while people are chewing and while people are washing their teeth. Let's try to understand what would happen if we don't have the connective ring, if we don't have the S-line, or if we don't have the platform switching. There will be a flat plane and the tissue will not have the chance to stabilize itself. So what happens that every time that the patient washes with a toothbrush or chews something, this tissue is moved. And this movement, they collect bacteria downwards and of course harms the profound tissues. The reaction of the bone will be a recession. And if the bone goes away, the supracrystal arteries will reduce the blood supply to the tissue. And after a bit, that tissue will go through recession itself. So let's see the outcome of this case. This is 6 months after the immediate loading. This is the final at 1 year, at 2 years and a half, and everything is very stable. Of course, we don't have the nasal papilla because there are no requisites in order to have that papilla, because the bone peak was very high. We tried to rebuild it, and now you will see by the radiograph, but actually this is a good solution for the patient and he is happy. So in the meanwhile, we made the implant insertion and immediate loading. It was performed a sinus lifting crystal approach, and in the meantime, the bone that was harvested from the implant site was used in order to have a rebuild of the interproximal bone peak, which is something very difficult to achieve, especially to have a full bone peak recovery. When we manage the emergence profile, we should know what is the tissue potential in order to understand if we can ask the tissue to creep or to displace in a different position. So let's have a look on what is the maturation potential of the tissue. I would like to call it the tissue equation. And again, I will explain this through clinical cases. In this situation, a patient had to remove this tooth, and we performed an immediate load because we had a very good initial stability of the implants. This is the immediate provisional positioning. Those provisional were not in function from occlusal loads, neither in lateral loads. This is the follow-up at 1 year, and this is the follow-up at 1 year and a half. You can clearly see that the proximal bone peak is very stable, and this bone peak is stable. Probably will give us some surprises. Let's talk about papillas. I asked the technician to higher the interproximal contact point when I delivered the final prosthodontics. But why did I do this? You can clearly see that there is no papilla between those teeth. Even from the palatal point of view, 2 millimeters of papilla are missing. But I have my numbers, and I will try to predict where this papilla is going to using the numbers that you previously saw at my presentation. So the bone peak is 2 millimeters over the interproximal connection of the implant. And the distance between the interproximal bone peak, which is this, to the contact point is 5 millimeters. The amount of keratinized mucosa in the buccal sides is 2.5 millimeters, and the width of the crest is very good. The buccal bone was more than 1.5 millimeters, so we have all the numbers to have papilla, highly predictable papilla. So what happens? Please look at the screen. Exactly at this point, you will see that this papilla, in few weeks, because it has the space, will mature and fill up all the clear spots. And again, from the buccal point of view, you will see this papilla maturing positively and filling up all the black triangles. Of course, this works if you plan correctly the contact points and if the patient has a very good hygiene condition. If the patient is not cleaning well, of course, nothing of this is happening. So when you change the emergence profile, every time you earn or you pay something. So let's go through the case and try to see what had happened. In this implant, I didn't need them much high, so I induced a creeping. In this, I induced a recession. In order to displace the gingival gum, the gingival line, upwards. From a buccal point of view, I wanted here to increase the width of the tissue without any graft, just prosthodontically, not surgically. And here I could let the tissue to collapse because I had more than enough. So if you increase the emergence profile, you will have as a response of the tissue more thickness and more tissue stability over time. But you could pay some gingival coverage. So let's see a scheme, drawings of this. If you increase the volume in that way, what will happen is that the tissue will increase the width over time because it will be protected and it will be sustained by the prosthodontics and it will increase the trophism. But if you reduce the emergence profile, tissue might go coronally, creeping on the top of the tooth. So if you want the tissue to go up, you can. You have to reduce the volume inside the tissue, let it collapse inside and protect a little bit higher. This is working only and I repeat, this is working only if you have stable interproximal full papillas with stable interproximal bone peaks. If you have full papilla and you reduce the buccal volume of the prosthodontics, the tissue will go upwards through the papilla direction. So what will happen is exactly this. Tissue will flatten higher where you placed the curve. So it will read the curve and try to stay next to that curve. Of course, you cannot move it half a kilometer. You can move it half a millimeter or 1 millimeter. So slight movement, very little ones, but perhaps in a static area, this movement might be the difference. So in these cases, I changed the emergence profile into different shapes because I want different effect in the two sides, just one next to the other. Let's have a look. So in one cases, I increased the emergence profile here in order to increase the thickness of the tissue. And over time it's very stable, so without any bone regeneration or tissue regeneration, only prosthodontically, I could increase the volume of the keratinized mucosa by pushing buccalwards. If you reduce the emergence profile and you go a little bit more straight, of course the tissue will collapse in the medial implant, and over time they will get at the same diameter because I treated them differently. From a buccal point of view, and you see here the free ear follow-up, in this situation the zeniths were at the same level, but reducing the emergence profile, I could guide coronally the tissue in a creeping way, and I could make the same height between the two teeth just by changing the emergence profile and guided tissue in their final position. In order to show you how much tissue can react, they will react very fast. This is a vertical fracture of a tooth, and the patient comes and it's late. She and he and we have no time to do immediate loading, and actually there is an inflammation, so I don't want to proceed for the surgery immediately because I want to solve the inflammation first. And it was also time to go home. That sometimes happens. But what I could do for this patient, due to the fact that he needed immediately the aesthetics in that part of the mouth, is that I removed that part that was broken. It was the buccal side. Part of the root was broken, and I flattened the surface of the root in this area with a burr, and I changed the emergence profile of the fractured tooth. And I glued it back. So after gluing it back, there is a gap between the root and the tissue. And the tissue, of course, it will collapse down. I have interproximal stable papillas, and what I might suspect is that this tissue will collapse in the directions of the interproximal papillas. So please have a look what happens in only 1 week. From here, the tissue drops in that position. So you change the shape of the emergence profile, the tissue will react. The free gingival margin will displace itself in a more convenient for you position. And of course, beginning from this moment, it's easier to perform an immediate loading on implants. Now it's easier. This is just 1 week reaction. So imagine what you can do. You can see from this point of view that the amount of gum gives us more safety in doing implantology in this area. You can always push gum upwards, but of course, if you have more gum than what you need, you are always happier. And of course, we could go through the surgery. So again, going at the point, we really need to have this S-line concavity and this convexity outside the emergence profile. But I promised you parameters, and this is the title that I was given. So when I was given the duty of this lecture, I was asked to give parameters on tissue maturation. So I'm very happy to announce that the RoFlab team, which is a team that is composed by my ex-students, we work a lot to find out these numbers that, of course, is very difficult to find out. We recently went in an amazing result describing how tissue matures in a 3D point of view in the buccal site next to an implant. So let's try to map these parameters and let's see how this tissue can get at this point and how this will influence your implant positioning in the daily practice. Wenstrom, a lot of years ago, in 1996, he discovered that there was a stable ratio between the width of the tissue width at the CAJ of the teeth with the height of the tooth. This ratio was quite stable between many teeth, and it's of course in favor of height, because there is a periodontal ligament that helps tissue to keep the height next to a tooth. But when you turn this system to an implant, it was measured by Nozawa that it completely changed the rule. So if before it was thick and 1.5 more time high, now is high and 1.5 more time thick. What means that we lost height. The amount of gum that was on the top of the base of that gum dropped down at the zenith point, buccal to the implant. So next to an implant, the extension, the apical, the coronal extension of the tissue cannot be so much if measured from the connection of the implant. It was supposed by some authors that the connection itself could be a problem, but it was not yet demonstrated. So let's have a look on these numbers. We changed the connection, the one used by Nozawa, and on 32 cases we could get to a complete different ratio. Our tissue at the same thickness were higher. So the amount of height, this V that you see here, was higher in our system, probably due to a better connection. So what we can say is that if we have a conical connection, the vertical extension of the tissue is more if compared to the vertical extension of tissue next to a flat-to-flat connection that was used by Nozawa. This is just a supposition, so in order to be a little bit more heavy in this pronunciation, we did a second study. In the first study that I'm describing, you can see here quite a complex graphic. This is the only complexity that I'm showing today. Here you can see in these numbers describes the width of the tissue, and here are described the years, during the years at the delivery of the final prosthodontics at 1 year and 2 years later, the height of the tooth. So we can monitor if the gum is going to recession or going creeping. And here we measure the height. In this graphic, I give a summarize. If you go in this part, you have average recession over years on the implants. If you go in this part of the graph, you generally have creeping, so you increase the volume of the tissue around the implants over time. We could measure that if you have less than 3 millimeters of width, of biologic horizontal width, this is a new term, you will have a recession over years. The height of the tissue will be reduced. But if you have more than 4 millimeters of horizontal biologic width from the connection of the implant to the surface, of the gum, you will have a positive maturation, a creeping of tissue over the years, not a recession. And this is another parameter that gives us the ability to be more predictable when we place an implant in a static area. And we of course want that in the follow-up we will not have a recession in that area. So, again, we can summarize this way. When we place implant, we should place implant due to these numbers if we have a good connection, deeper than what we are used. So if the connection allows us to do, we should go deeper in order to reach 4 millimeters of distance between the connection of the implant and the surface of the gum. And from the other data, 1.5 millimeter of buccal bone is the quote of bone. And of course, the depth of the implant can be supported up to 4 millimeters. Also, in the study that we made before, 4 millimeters were the best positioning for this kind of connection. But please remember that these indications are only for this connection, because if you change the connection, the indication changes. And I would like to show you why. This was the data that I showed you before, the one on a prospective 5 years follow-up with 202 variables per implant, and we measured that the best performance in order to reduce the bone recession around implants was 4 millimeter of transmucosal height. So from connection to free gingival margin in the buccal side, 4 millimeter was the magic number. Let's try to see if this 4 millimeter is so magic even in a more big study. This study took two of my best students, a work of 1.5 years, measuring models, and they retrieved 294 implants scanned in the model, and there was a 3D analysis with clinical data. So 294 implants is a huge work to work 3D and do all the rendering and the measurements. So I really need to thank them publicly. And this, what you just saw in the background, is their Excel, which is very, very long. And what they did is they digitalized every model of delivery of final prosthodontics that was delivered at 1 year after the implant placement in this protocol. And they could measure again the tissue width from the implant connection and the tissue height from the implant connection line. And this measurement, of course, is extremely precise. So now we can give on wide samples, because one Nozawa used only 17 cases, and we had 32 in the second study. Now we have almost 300. So it's the widest number on this data that you can see. More into detail, they again measure the buccal tissue width and the buccal tissue height in the zenith position of the tooth. Again, you can see that there is a tendency of all these numbers to reach the magic number 4. And again, the buccal tissue height, so the transmucosal distance between the free gingival margin and the connection of the implants, was tending to 4 millimeters again. So again, that is a magic number. But what is cool of this study is that we could compare different implants. In the specific, you can see that there are this group of implants which are represented 5 degrees per side connection. In particular, this is any region. And the blue number, 3.9, is the buccal tissue width, so the amount of tissue from a horizontal point of view. And corresponds to this a ratio of almost 1 to 1. So if you have almost 4 millimeters in width, you have 3.5 in height. So this is what this connection can give as a maturation over time. But if you change the connection and you go in a flat-to-flat connection, you can see that even if the width of the tissue is the same, dramatically decreases the height of the tissue. So what happens is that this tissue will retract and give a recession. So if you have a flat-to-flat connection, even if you have the correct width of the tissue and the correct size of the bone, the tissue will recede the same. And this is highly significant. And again, this could be, of course, connected to the pumping effect of a connection. What is the pumping effect? Actually is what happens every time the patient chews. The connection is not a perfect seal. There's no article yet that describes clearly, without bias, that the connection of an implant can totally be sealing the connection. There is always a pumping effect, but in the conical connection is much lower compared to the flat-to-flat connection. And these movements, of course, what you are seeing here in the movies are only with 20 kilos. Imagine in the mouth you can reach over 80 kilos. So probably it's worst just next to the bone. And what happens is that these micro movements, which are not only sagittal but also rotational micro movements, gives at the end a leakage of bacteria and endotoxins. It's a little bit long to explain into detail, but you can imagine that cells, water, proteins, bacteria go inside the implant at a masticatory cycle. And it stays incredibly at incubation at 37 degrees for long hours until you have a second masticatory cycle. And they will produce endotoxins and bacteria. They will be expelled at the secondary chewing cycle. And of course, the epithelium will go deeper in order to let this toxic substance to evacuate outside. So the pumping effect, of course, is something that affects negatively the implant and the tissue surrounding the implant. This was well known until just on 1986, Albrechtson discovered that next to the implant, bone was going away 1.5 millimeter in the first year. And this was described as success. Of course, now we know why this happens, and now we know that this is no more a success at nowadays level of expectancy. So when you place an implant, you should place the implant more palatally, and you should place it in order to have at least 2 millimeters in the buccal bone, and of course a total 4 millimeters of tissue thickness from the connection to the surface of the tissue. What's the depth that you should place it? 4 millimeters from the gingival line, because this keeps very stable over time. But don't do this when you have a flat-to-flat connections, because you will have a recession for sure. So please do this positioning only if you have an efficient connection. Otherwise, you will have a recession in the frontal area and will not be happy, nor you nor the patient. So I'd like to conclude with the last case, and this patient was highly demanding in terms of aesthetics, and it's quite a long story, but I will summarize in few slides. He wants a perfect aesthetics even if he has a recession. So I will place an implant, a provisional, and I will let the tissue mature using those considerations that you just saw up to now. This is 8 months post-op, 1 year post-op, and this is the relationship with the tissue. The emergence profile is very horizontal, so I leave a huge amount of volume for the tissue. You will see the tissue are completely not inflamed. I'm not invading the biologic width, but I'm keeping the horizontal biologic width safe, 4 millimeters. And you can see the relationship with the anatomical structures. The bone is stable and the implant is in the correct prosthetical position. So again, you can see a 2-year follow-up. The stability of the tissue is high. The stability of the bone is high on this kind of connection and on this kind of implants. Those kind of threads, of course, helps me giving very good primary stability and reducing the bone reduction during the insertion. You can see the follow-up at 3 years. Tissue are really stable and the Increased emergence profile helps keeping the volume in place. At 4-year follow-up, again, everything is very stable and the volume is kept in its position due to the emergence profile and the correct implant connection and position. So what is the take-home message of this webinar? And I really hope you enjoyed the little time we had together. Please try to keep in mind that the distance between the interproximal bone peak and interproximal contact point should be less than 5 mm. If you don't have this, you might not have a full papilla between implant and between implant and tooth. There will be a chance not to have the full papilla. Please try to have at least 1.5 mm in the buccal bone after implant positioning. So please place narrower implant compatible with the mechanical duties of that place. Place the implant a little bit more palatal or lingual, but leave always at least 1.5 mm in the buccal side. If you can't, it's a good time to do bone regeneration, so please do something to increase the volume of the bone in the buccal side. This will prevent recession over time, especially in the static area. Remember the magic number 4 and the magic number of the bone volume in the buccal area. This again will prevent tissue recession over time. And use implants with a design that gives you very high stability, very little time of osseointegration, but not reducing the buccal bone. So smooth or knife threads helps keeping the buccal bone very stable even during the surgical insertion, as you saw in the videos. And please apply S-line emergence profile with your technician in order to give the maximum space for tissue, for nature. Remember, titanium, resin, and ceramics do not feed cells. The more space you leave to nature, the more nature will be stable over time. And use a convexity outside the free gingival margin in order to mechanically protect the tissue surrounding the implant. Use the emergence profile guidance in order to fix and refine the position of the tissue, so you can get to perfect symmetry between natural teeth and implants one next to the other, which is the most difficult thing to do generally in the frontal area. Try to achieve a very good hygiene of patient, because if the patient is not working with you with the same target, with the same hygiene that you wish he has, you will never have such tissue surrounding the implant. So please try to achieve perfect tissue around implants. No compromise on the hygiene level and on the emergence profiles. Everything must guide tissue in the final positioning. See again the tissue volume in the buccal side. Please do something to increase it, even with tissue graft, in order to have 4 mm of tissue thickness in this area. If you reach this target will be very stable over time. And again, try to use your emergence profile in order to stimulate the volume of the surrounding tissue and to guide them into a very good nature mimetism, biomimetism. So explain to your patient whatever you know, because the more the patient knows and the more he will work with you in order to have an alliance for a common goal and a common result. I feel very honored to be here with you, and I really hope you enjoyed the session, and whatever question you have, I'm ready here to answer at your question. Have a very nice evening or day, whatever time is in your country, and I hope to see you soon. Email me whatever you need. Thank you very much. Bye-bye.